Okay, so good afternoon. Thanks for coming. I know, especially those of you in person, today is a hard day to get to campus, so thanks for being here, as well as those over Zoom. And today the format is a little bit different than usual. We have not one, but three excellent speakers. We have Daria Oleinichenko, Rusong, and Isabella Gallello. The three of them are PhD students in the Department of Psychiatry, and they're all co-supervised by the Phillips lab, as well as in combination with the Snutch lab, the Seamans lab, and the MacVicar labs. So we're going to learn some about the overlap between these two projects, which is on the translational animal models and drug candidates for opioid induced withdrawal. So thank you, and I'll pass it on to Daria.
Okay. Thank you, Lily, for such a wonderful introduction. I'll dive right into the gravity of the situation which we're discussing. Opioid use disorder has a great cost on our society in terms of socioeconomic sphere and the medical sphere. And in the graph over here, 1 second, I shall.
I'm sharing the slides over Zoom.
Oh, I thought you did that. Oops. Okay, so screen, here we are. Share. And then, okay. Right. Okay. So that should be all good.
Yes.
Okay. So back from the top, the opioid use disorder has a tremendous cost on our society in terms of the socioeconomic and medical spheres. This graphic over here is just for the province of BC from 2016 to 2022, which is the most data we have publicly available. And you can see that during this time, illicit drug toxicity deaths have cost so many lives to our province and to our humanity. So since 2016, daily deaths from illicit drugs have more than doubled, with 6.3 people dying every day in 2022. And at least a quarter of these drug-related deaths are directly due to misuse of opioids. The recent efforts of the province to ensure a safe supply by decriminalizing carrying of illegal substances was not tremendously effective, with 6.1 lives lost daily in October of 2023 alone. And soon we will have more complete data for the 2023 set, but it is not looking bright for substance use disorders in the province of BC. And it is clear that helping people achieve remission will prevent drug-related deaths. It is an extremely complex disorder with a lifelong battle, and the treatment plan is complex it's a multi-stage process, but the first stage to achieving remission is detoxification from drugs. And opioid withdrawal syndrome is a tremendous barrier for these patients to achieving freedom from drug use. While coming off of opioids, people may experience severe somatic symptoms and dysphoria, and not least of these symptoms is pain, which we will refer to as withdrawal-induced hyperalgesia. There's been some studies that summarized clinical evidence in heroin users. And this graphic here shows that people in acute withdrawal from heroin of under 72 hours, shown in black, have decreased pain tolerance compared to naive volunteers, drug-naive volunteers in white. And even ex-users who have abstained from heroin for a significant amount of time, shown in gray, still still exhibit a reduced pain tolerance compared to people who've never used drugs. So there's a trend for incomplete recovery from the pain syndrome that people experience during withdrawal. And this pain syndrome is positively correlated with motivation for drug use or craving. So are we doing anything about this as a society? Well, the current treatment options are well known, but we will talk a little bit about how they do not completely address this barrier for remission, such as pain. So first well-known treatment for opioid use disorder is the long-lasting opioid replacement with methadone or buprenorphine. And it is able to decrease the tendency of people to relapse to illicit opioid use by 33%. However, up to a quarter of patients do not complete treatment for different reasons. And while being on long-lasting opioids reduces the likelihood of overdose happening in these patients, it is still possible in an event of relapse that they will overdose on opioids because these are opiate substances. So in the last few years, FDA has approved the first non-opioid treatment for opioid use disorder, which it deserves the mention. It is lofexidine, and it is an alpha-adrenergic agonist, which balances out the somatic symptoms caused by an increase in noradrenergic tone that people experience in withdrawal. It increased the likelihood of people completing the course of detoxification by 14% compared to placebo, which is a win, but a modest one at that. And its unpleasant side effects, such as hypotension and sedation, contribute to patient attrition from treatment. And as I mentioned before, addiction is a complex disorder. There's social, economic, and environmental determinants aside from the biological ones. But as neuroscientists, we strive to better understand neurobiology of opioid withdrawal and try to provide innovative treatment approaches based on these recent advances. So this presentation will cover our interdisciplinary approach, which we're quite proud of. And first, I will begin with a chapter of something I'd like to call something new, something old, something new, phytochemicals versus novel target-specific drugs, in which we'll discuss two radically different approaches to treating withdrawal-induced hyperalgesia. And then I will introduce Rusong, who is diving into perspectives beyond conventional brain chemistry, and we'll discuss neuroglial involvement in withdrawal and its treatment. And finally, we'll have Isabella Gallello, who will talk about the involvement of anterior cingulate cortex in shaping distress and emotional pain, in shaping behavioral responses to distress and emotional pain. And hopefully provide evidence of neurobiological correlates of hyperkatifia in the future. Okay, so let's start by walking through how we are striving to preclinically model opioid withdrawal-induced hyperalgesia. From previous studies, we know that even a single treatment can cause lasting hyperalgesia. However, that doesn't fully recapitulate the biological trends that happen in chronic drug abuse. So in 2021, the Koob lab came out with a paper that used a chronic intermittent access model with 5 days of opioid treatment, followed by 2 drug-free days, repeated on a weekly cycle. And this approach is believed to recapitulate more fully the chronic intermittent nature of disorder and the drug-free periods that may happen to patients due to lack of drugs, due to their failed efforts to detoxify from these drugs. And there are valid biological correlates to this approach. It is believed that this pattern of drug administration causes more pronounced fluctuations of dopamine in the nucleus accumbens and more pronounced hypodopaminergia during withdrawal, which is fairly well validated to be a determinant in drug abuse. And recently, Phillips lab has published another study that showed that only prolonged morphine treatment in a chronic intermittent manner revealed hypodopaminergia in the dorsal striatum specifically. So there are also regional differences in how sensitive the brain is to repeated intoxication withdrawal periods. And this should not be overlooked in future studies. But in terms of the behavioral modeling, the Phillips lab has used male Sprague Dolly rats that would receive once daily morphine at 15 milligrams per kilogram, and 23 hours after their last injections, the animals would undergo the von Frey test, where they are placed on a metal grid floor, and a transducer is pressed to their hind paw until a response is elicited. And at that point, their maximum force in grams is recorded as their pain paw retraction threshold, or their pain tolerance threshold, we can say. So when I first modeled when I first modeled this approach, I took a repeated baseline to ensure everything was clean, and then animals underwent a 3-week morphine treatment regimen to induce hyperalgesia. And after 3 doses of morphine, they already started to experience a significant, oh, my laser went away. They already started to experience a significant decline in their pain tolerance, which continued to drift down as the treatment continued. A vehicle treatment did not improve their pain tolerance, and as long as animals received morphine, there was a persistent hyperalgesia displayed in our model. However, to make it more clinically relevant, we wanted to see what would happen if animals were put in a detoxification scenario. Does the hyperalgesia persist after the morphine treatment is ceased? So after their initial 3-week hyperalgesia induction, animals were transitioned off of morphine treatment regimen, so no more morphine, and they started receiving daily oral infusions of vehicle, which is an acid. And that did not improve the hyperalgesia. So we can infer that the hyperalgesia persists during this initial week of detoxification. Finally, in the last 2 weeks, the animals were continuously monitored for hyperalgesia and they, so I'm going to take a sip of water. As you can see, in a complete drug-free state, and the hyperalgesia persists for about 2 weeks after starting to until it spontaneously recovers back to baseline, which is rather consistent with the clinical implications. So far, I demonstrated that we were able to achieve stable hyperalgesia in rats in acute morphine withdrawal, and this increased pain perception continued during drug abstinence, which is in line with what with the first study I showed showing heroin users and their hyperalgesia. So then we wondered, are there any therapies we could test out to see I'll backtrack a second. So then we wondered if there are any therapies we could test in this model to see if it would be effective in this model. And obviously something promising for this type of disorder would be something showing preclinical evidence and analgesic potential. So our first drug of choice was L-tetrahydropalmitine. So L-tetrahydropalmitine is a tetrahydroprotoberberine, THPB. I will not say that again. And it is a primary, it is a phytochemical and a primary acting compound of Hyanthus 4, allegedly, which is a drug for, it's a natural remedy formulated from several plant derivations. And it has been used in Vietnam for OUD treatment for several years in the clinic, and it has recently been awarded a natural health product license under the name of TGIR in Canada. Pharmacologically, it is primarily a partial agonist at the dopamine D1 receptor and an antagonist at the dopamine D2 receptor, although it is a rather dirty drug. And in the brain, it tends to act as a dopamine stabilizer, where it dampens the hyperdopaminergic states and elevates dopamine during hypodopaminergia. It is also known to interfere with expression of self-administration and condition-place preference in preclinical models of opioid use disorder, and importantly, exerts non-opioid analgesic action. So in this mouse model of neuropathic pain, animals were given 10 milligrams per kilogram of LTHP, and that helped them recover back to baseline levels. So what would happen if we administered LTHP into the model to animals that have undergone through hyperalgesia induction concurrently with morphine treatment? So the answer is it works. At 5 and 7.5 milligrams per kilogram, LTHP effectively alleviated hyperalgesia in our model and caused a 37 and 47 increase in pain tolerance, respectively. So next, we would like to move that to a more clinically relevant aspect and see if LTHP promotes pain relief in detoxification, in a detoxification scenario. So like described before, after morphine cessation, animals were onboarded on a week-long treatment of LTHP. And during this treatment week, animals experienced significantly less pain than the vehicle-treated group. And most amazingly, this effect persisted during the period where they received neither LTHP nor morphine. So early intervention seems to be conducive to recovery from withdrawal-induced hyperalgesia. So to quantify this a little bit better, how much is LTHP really helping? We tracked the first instance at which animals showed a recovery to within 95% of their pain tolerance baseline. And LTHP-treated animals took about 5 days to recover to near baseline levels, where vehicle-treated animals took close to 15 days. So it's a threefold difference. Yay, it worked. Is there something else that we could do? It's a bit of a spoiler. I was supposed to remove that. So next, we turned our minds to Z944, which has been investigated by the Snutch lab. And it is a selective T-type calcium channel blocker. A quick overview on T-type calcium channels. They are very uniquely positioned for fine regulation of neuronal excitability because they are activated very close to the membrane resting potential of neurons. And because of that, there are common targets for anti-epileptic drugs. As a matter of fact, Z944 is currently in clinical trials for that. And anti-epileptic drugs are commonly very good agents for neuropathic pain. T-type calcium channels are highly expressed in the ventral tegmental area, the brain reward master region. The spinal cord, where the sensory stimulation passes through, and the GABAergic neurons of the periaqueductal gray, which are the controllers of, which put the brake on the descending pain modulation pathway that leaves the PAG. And interestingly, as was found by the Phillips lab, by a student in the Phillips lab, Z944 blocks reinstatement of conditioned place preference to morphine. So in animals that previously showed preference to a morphine-associated side of the apparatus, and then undergone extinction to where the preference was no longer observed, a single challenge of morphine was given to reinstate their preference to their association of a specific chamber with morphine. However, Z944 pretreatment at 5 and 7.5 milligrams, especially at the higher dose, successfully prevented this reinstatement of a reward association of craving some main fur. And relevant to what I'm talking about here, it has previously demonstrated efficacy in neuropathic and inflammatory pain. So, could we give this to rats in withdrawal? Would this work? Yes. It works beautifully. It helps restore, at 10 milligrams per kilogram, Z944 helps restore pain tolerance in animals to near baseline levels during acute withdrawal. What about animals in protracted withdrawal? Animals in protracted withdrawal show similar patterns where they have successfully recovered to near baseline levels. And this likewise, like with LTHP, this trend continues after the treatment has stopped. And their time to recover to baseline is reduced further to 3 days, although that may be an attribute of a higher dose than with LTHP. With LTHP, we kind of kept it close to home. Okay. So to conclude my section, I'd like to give you a little bit of an overview. Both LTHP and Z944 improved hyperalgesia during acute and extended withdrawal and accelerated recovery. And from what I found, it appears that analgesic intervention during transition to abstinence may improve clinical outcomes. So we're hopeful. So now I'd like to pass it on to Rusong, who will take it away with neuroinflammation.
Yeah, thank you. Okay, so it's my turn, and my name is Rusong. As a PhD student who's co-supervised by Dr. Phillips and Dr. MacVicar. And yeah, today I'm just gonna present my story from the immunoinflammatory perspective on the morphine withdrawal-induced hyperalgesia. And thanks to Daria, she gives us a very comprehensive introduction about the opioid crisis, and also the necessity about why we wanna focus on the morphine withdrawal, and especially the negative affections involved in that. And in very long term, and including Daria's data, show that people seeking for medicines targeting on neurons. But my project is kind of trying to find a new therapy beyond the neurons. So because the limitation of techniques, and also the mu opioid receptor is the predominant receptor for the morphine. So it makes sense that people are seeking targets on neurons. But in recent 2 decades, like growing evidence just appears regarding the involvement of neuroinflammation in drug addictions. So in human studies, it's a transcriptional study, and we can find that multiple inflammation signalings like tumor necrosis factors alpha and like cytokine mediated signaling pathways are getting involved in the opioid use disorder patients. And more specifically, as the immune cells in the brain, the microglia markers was significantly enriched in the opioid use disorder patients as well. Because of the subfield is so new, so most of the studies are conducted in preclinical animal models. And and it is true that because some varieties medicines that are used in clinical, like aimed to treat other diseases, could reduce addictive behaviors by inhibiting the activation of glial cells, as well as their downstream cytokine productions, thus resulting in a less level of inflammation in the brain. So all those evidence show that probably we can find some targets from the neuroimmuno perspective. So our lab has a very reliable morphine withdrawal-induced hyperalgesia model. And what should I do in my project to investigate the inflammation? Which pathway related to the neuroimmunology contribute to the hyperalgesia more specifically? And as the resident immune cells, do microglia and how microglia contribute to the hyperalgesia, and which brain regions of microglia like play roles in the hyperalgesia? Is the immune system also in like a similar way as neurons did that has a brain region differences? Like all those questions are like quite interested, and we still don't know the answers. So that's kind of an outline on my story as well. I'll just look at those questions in my following presentation. The pathway and the first target I want to look at is the toll-like 4 receptor. The reason why I'm quite interested in this receptor is because in 2009, several labs found that the opioids can bind to the toll-4. The lipopolysaccharide, which is an outer membrane of negative gram-bacteria, can trigger a strong inflammation upon stimulation in individuals. And the morphine and other opioids did the similar thing, that the morphine can bind to the toll-4 receptor, can bind to the same, the toll-4 can bind to the same binding site as the LPS and activate toll-4. And toll-4 will recruit the MyD88 and the CD14 to form a protein complex and recruit like MyD88 and the TRIF proteins separately, and product the cytokines or chemokines to induce or increase the inflammatory levels. And as I mentioned, that the toll-4 has 2 signalings. Like the toll-4, like another reason why I want to look at toll-4, because the toll-4 is both involved in pain modulation and also the drug addiction. So the toll-4 in spinal cord participates in transition from acute to chronic pain. And also it can, Oh, yeah. And it also contributes to the maintenance of pain. And in the other hand, the TOL4 antagonist can attenuate multiple symptoms of withdrawal symptoms. However, because of the complexity of morphine treatment and also like the complexity of the TOL4 signalings, because it has like two sub pathways. So we cannot get an inconsistent result across studies. So that's why I want to go further on the TOL4. And I think there are several possibilities. Like one, as I mentioned, like the inconsistent results coming from the complexity of morphine treatment, and also like the subpathways of the TOL4. And since the chronic morphine treatments can increase the expression of the MYD88 in spinal cord, so I think probably the TOL4 MYD88 pathway is like more important in morphine withdrawal, especially the hyperalgesia. I'll talk this a lot like more later, but here I just like want to mention this, that the TOL4 mainly expressed on microglia, partially on astrocyte and in the brain, which gives us target cell type of those immune cells. So I'll look at the microglia later. So I think we all know that the inflammation is kind of chronic results. So I'm just wondering that if I block the TOL4 MYD88 pathway chronically, what happened to what will happen in this hyperalgesia model? So in my study, I'll just use exactly the same morphine treatment protocol as Daria introduced, with 5 days of the continuous morphine injections, and then followed by 2 days without morphine injection. And this circle will be repeated for like 3 to 4 weeks, depending on like which kind of experiment I was conducting. So here, those rats received 4 weeks of the morphine treatment. To block the TOL4 MYD88 pathway, here I use this interferon peptide, MYD88. So this peptide is developed by MacVicar and Phillips labs, like around 10 years ago. And this peptide is a cell-penetrated peptide, which means it can go into go through the cell membrane. So this peptide can just block the binding between the TOL4 and its adapter protein MYD88. So once LPS, let's say in my study, morphine coming here and bind to the TOL4 and activate the TOL4, but the TOL4 triggered downstream cascade can be blocked here by the MYD88. So the cytokine production and like other transcriptional modulations can be inhibited. It's okay. It's good to hear my son. So yeah, so this pathway, like all the functionals like by activating TOL4 can be inhibited by the MYD88. So I give those rats the MYD88 to block this pathway, like system via IP injection, half an hour before morphine injection, before every morphine injections from like the very beginning of the morphine treatment. So what we can see is for the saline rats, we can see a quite stable pain threshold, like was maintained for 4 weeks. And after a long term of after 4 weeks of the morphine treatment, we can see a significant hyperalgesia present with like a reduced bowel retraction threshold. And like after I inhibiting the toform-MyD88 pathway, what will happen? So you can see that there's no hyperalgesia in rats who receive the MyD88 anymore. Which means like if we block the toform-MyD88 from the very beginning of the morphine treatment, then like no hyperalgesia will be observed later after like long term of the morphine treatment. And I got another control group of the 10 scramble peptide. So the TAT itself just did like we can see a significant hyperalgesia in the 10 scramble peptide rats, which makes sense and prove that the TAT itself did nothing. And also the MyD88 itself did nothing to the pain threshold as well, which is quite cool, I think. But for like in clinical trials, it's just impossible that we gave them medicines from the very beginning of the morphine treatment. So patients seeking for therapy because they have already developed into hyperalgesia. So so I'm just wondering, like in our animal models, what if we inhibit the toform-MyD88 in well-established hyperalgesia rats? So that's what I did. I gave those rats morphine treatments for still 3 weeks. And at the end of the morphine treatment, we get well-established hyperalgesia rats. And on the first day of after terminating the morphine withdrawal, after terminating morphine injections, I gave those rats systemically administration of this MyD88 to see whether there's any acute effect of the MyD88 on the pain on the hyperalgesia. So that's control group. So we can still see the hyperalgesia here, which make a lot of sense. But for the rats who received MyD88, we can see a partially reversal effect of the MyD88, which means like if we systemically inhibit the toform-MyD88 pathway, then the hyperalgesia could be rescued. So it's possible that we use this target in clinical trials. But how long the effect can be maintained? Will the reversal effect just disappear after the stop of the MyD88 administration, or the reversal effect will like be maintained forever? So I keep testing for another 2.5 weeks. And to make the data clear, I normalize those data of the pain threshold that are measured from the last one-free test. And we can see that the baseline, they have the normal baseline level of pain threshold, and morphine treatment just reduce the pain threshold, which means hyperalgesia. And the field column is from MyD88 rats, which showed a partially reversal effect compared to the control group. And for the following morphine detox, like during the following morphine detox period, we can see that the reversal effect was being maintained for at least 2.5 weeks compared to this control group, which was amazing to me. Because you know, only 3 days of the TMID88 treatment can have are so powerful that it can just reverse the hyperalgesia for forever. So now we know that if we block the TOFOMID88, we can see acute reversal effect in those hyperalgesia rats. So I'm just wondering what happens in the brain. What happens to the microglia? Because I mentioned that the TOFO mainly expressed on microglia. So that makes a lot of sense for me to look at the how the microglia changes. A little bit more about microglia. So microglia is one of the glia cells, and it comprises between 5% to my mistake, to 12% of the cells in the brains. And microglia actually has a lot of functions beyond the inflammation, and it can eat debris from neurons and other types of cells, and can program the cell death and pruning synapses and regulate the neuronal plasticity. And in pathological conditions like Alzheimer's disease or Parkinson's disease, and stroke, and a lot of diseases, so the microglia can release the cytokines to increase the inflammation. And in the Alzheimer's disease, the microglia can help to clear the A-beta plaque as well. So though the microglia has a lot of functions here, its morphology also is also dynamic, has many many shape, many types of shapes. So in healthy brains, the microglia is ramified with branches like this. And in diseases or upon injuries, the microglia will become will turn to amoeboid shape, featured with enlarged cell body and shortened and less processes. So we can use the morphological changes of microglia as a character that the microglia is doing something. So in my study, I used the morphological changes of microglia as a feature that microglia is working on the neuroadaptation caused by the morphine. So what I did is to give my rats morphine injections for around 5 weeks, and on the big day, on the last day, I gave them 10 scramble and MID88 half an hour before the last morphine injection, and 2 hours later, tissue was collected and did an immunostaining for IBL1, which is a marker for microglia. So in healthy brains, the microglia looks like this. So we can see that microglia is ramified. Back to my initial slide that I mentioned, I'm just wondering that whether there's some brain region differences involved in the whole processes. So I screened multiple brain regions to see which brain region was affected, microglia in which brain region was affected the most, and whether blocking the TOFO-MID88 did something to the changes induced by morphine. And well, I find this brain region, it's ventrolateral periaqueductal gray. Like the ventrolateral PAG is such a unique brain region because it is involved in drug addiction, aversion, and also pain modulation. So like all those functions position the ventrolateral PAG to like it has like a potential function in our hyperalgesia model. And so I look at the microglia in the ventrolateral PAG. After long-term morphine treatment, we can see the microglia turn to this with like, it's quite significant. You can see the difference with less processes, and the length of the processes are much, much shorter than the microglia in healthy brain. And this morphological changes can be reversed by the TAT-MID88 application. And I did several analysis for the morphology of microglia, and all the results show that the morphine reduced microglia complexity in shape and processes, which were prevented by the TAT-MID88 acutely. So that's some structural changes I showed here. So what about the functions? So I tested the cytokine mRNA as well in the ventrolateral PAG, and I found that the TAT-MID88 administration can reduce the cytokine production in the ventrolateral PAG, and all those cytokines are pro-inflammatory cytokines, which is good because we both found the structural and functional changes functional changes by morphine, and which can be reversed by the TAT-MID88 application. Well, so I found a target now via some chemical and biological methods. So what if I inhibit the TOFR-mediated pathway in the ventrolateral PAG? Like, what's the effect on the behaviors in our hyperalgesia model? So I implanted cannulas into the ventrolateral PAG bilaterally, and after like 1 week of recovery from the surgery, I gave those rats morphine injections to get a hyperalgesia rats. And on the first day, like on the first day of after I stopped the morphine treatment, I infused the TAT scramble or the TAT-MID88 into the ventrolateral PAG only bilaterally to see like whether inhibiting this pathway in the real ventrolateral PAG has an acute effect. So the result here is the control group, like the rats from the control group still in hyperalgesia state, which means like all those manipulations and actions of the drug delivery has not like slightly effect on the power retraction threshold, and for like rats who received TAT-MID88 microinfusion into the ventrolateral PAG, the hyperalgesia was reversed significantly. It's very beautiful data. I love this. And still the same question. What's the next? Is there any carryover effect during the following extended morphine withdrawal period. So I keep the morphine testing for another 2.5 weeks, as I described before, and a similar graph here. So we see a baseline over here, and the morphine treatment causes hyperalgesia, and inhibiting toll-4-mediated into the ventral lateral PAG reverse the hyperalgesia beautifully. And then it seems like for the rats who received TAT-88, it seems that there is a slightly drop of the reversal effect, which makes a lot of sense to me, because it is like the TAT-88 is infusing to the PAG only, and it's just a 3-day microinfusion. So I didn't expect it, I didn't expect the reversal effect can last for a very long time. But if we keep an eye on the recovery processes of the hyperalgesia, we can see that compared to the control group, the rats who received TAT-88 seems recovered faster. So I quantified the days returned to 90% of the baseline. The control group, it took 17 days for those control rats to return to 90% of the baseline. But for rats who received TAT-88, they recovered faster, around 4 days on average, which is great. Though the local inhibition of the toll-4-mediated cannot, the reversal effect from the hyperalgesia by locally inhibiting the toll-4-mediated cannot last forever, but it can still promote the recovery of hyperalgesia. So that's basically my whole story. It's a summary that so the toll-4-mediated signaling contributes to the development of morphine withdrawal-induced hyperalgesia, and only 3 days of systemic inhibition of toll-4-mediated rescued the hyperalgesia and forever. And acute inhibition of toll-4-mediated reverse the changes in microglia, both in morphology and functionally. And I confirmed the involvement of toll-4-mediated on microglia in the ventrolateral PAG in the expression of hyperalgesia. So we can hypothesize this. Morphine activates the toll-4-mediated pathway, triggers the downstream cascade, and resulting in increased cytokine production and regulates neuronal plasticity. That could be part of the reason that why there are some neuronal adaptations after morphine treatments. So overall, I think the toll-4-mediated signaling on the microglia could be a potential target of novel therapy of treat like opioid induced hyperalgesia. So yeah, in a non-neuronal way. That's my last word. And that's my part. And as we all know, multiple brain regions are involved in drug addictions. And the prefrontal cortex, ACC, is the most a very important one. So Bella will keep presenting her story on the prefrontal cortex. Thank you.
Okay, so I'm going to begin with the third part of our talk now, which is where distress may become emotional pain. So looking at the anterior cingulate cortex and putting more of a focus on the emotional aspect of the pain as opposed to the physical side. So hyperkatifia is a term that Dr. George Koob came up with, and this is used to describe the hypersensitivity to emotional distress that we see in people with opioid use disorder, that happens when access to the drug is prevented. So this can be best thought of as an emotional parallel to hyperalgesia. So instead of an increased sensitivity to a physical stimulus, you have an increased sensitivity in reaction to emotional symptoms that occur. So any kind of negative emotional experience will be perceived as highly aversive. And this provides motivation for drug seeking via negative reinforcement. So in this way, the individual is continuing to take the drug in order to maintain their mood to a more baseline normal state. We do have evidence of this in human populations. So the figure on the right here is the Karkoba paper, which is actually the same paper Daria presented in the beginning. So while they were looking at the differences in pain threshold between users and non-users, they also investigated how negative affect affected this pain sensitivity. And by inducing a negative affect in people, by showing them images that were designed to provoke negative feelings, they showed that this increased pain sensitivity only in the individuals who are experiencing drug withdrawal. And then we also know just from population data that the higher levels of stressful life events correlate the greatest with a risk of relapse. So in the general population, people tend to relapse when faced with great levels of stressful life events. So I'm Jeremy Seamans' student. I wouldn't be up here talking about any other brain region otherwise. I think the anterior cingulate cortex is a very important place that we should be looking. Firstly, for its role that's been documented in pain, both physical and emotionally. So we've seen in animal models that if you inhibit activation of ACC neurons that project to the spinal cord, you can then decrease withdrawal thresholds. Also in human studies, if you remove the cingulate cortex, you're able to treat chronic pain in about over 60% of patients. And these are patients with pain that has not been treated. It's impossible to treat in any other way. So the cingulate, removal of the cingulate is their last option, and it's able to cure it in about 60% of these patients. But the most important finding from these studies is that when you interview these patients afterwards, they'll tell you that their chronic pain isn't gone. It's still present. They still experience it. They can tell you where it is. It just doesn't bother them anymore. They're able to go through life and function while this pain is occurring because they're able to put their attention on other things. So this has kind of led collectively to the idea that the cingulate is not generating pain itself, but it's representing these painful events and then modifying how we're able to react to them. And we've also seen a role for the cingulate in addiction. So we see increased activity in the cingulate during withdrawal in mice as well as in humans. And if you inhibit this increase in cingulate activity, you can then block those withdrawal symptoms. And surgical removal of the cingulate has also been done. So these are in cases of people where the cingulate was done for the addiction specifically, or it was done for pain, but because they had a chronic pain condition, they were on a prescription of opioids that they had an addiction to. And in a majority of these cases, these people after surgery show no signs of withdrawal and then are then able to maintain abstinence after the surgery. Suggesting that there's an association with an increased activity in the cingulate during opioid withdrawal. And if we block this increase in activity, we can then attenuate the withdrawal symptoms that occur. So one of the things that we think might be contributing to this increase in cingulate activity is changes in the dopamine that are occurring in the cingulate. So there's 4 major dopamine pathways in the brain. The one you'll hear the most about when reading studies on addiction is number 3, so the mesolimbic pathway, and this has to do with rewards processing, and particularly the positive motivation to seek drugs. But I'm hoping after my talk today that you'll put more emphasis onto the mesocortical pathway, which we think seems to have a lot more to do with the negative affect side. And there is very little that's been done on the mesocortical pathway as far as conclusive evidence of what we know is happening. So for the mesocortical dopamine system, we've seen huge correlations with dysregulation in this symptom or in this specific system and a host of psychiatric disorders. And there's a high comorbidity between these psychiatric disorders and substance use disorder. We know that this system is particularly aversive, particularly sensitive to aversive states and stressors. So we see really large increases in dopamine in the mesocortical dopamine system when experiencing aversive states. If we modify these changes in dopamine activity, we can modify pain responses in both directions. But more interesting was the finding that came out that actually any event that causes autonomic arousal can increase dopamine. So while it was primarily thought that it was sensitive to aversive states and stressors, we were able to find that by providing more rewarding states, there was also this increase in dopamine. So it's regardless of the valence of the event, if this event is important, it will lead to an increase in dopamine. So this led to the collective hypothesis that maybe the dopamine in the cingulate is encoding the salience of an event. So anything that is important will lead to an increase in dopamine, and that will cause the cingulate to then signal to other brain regions that some kind of reaction is necessitated. So one thing that we think might be affecting these dopamine levels is the state of withdrawal. We know that there's differences in basal extracellular dopamine levels in the prefrontal cortex in withdrawal. And if you further precipitate this withdrawal with naloxone, you can lead to other changes. This study found that the dopamine was increased by withdrawal. It's a bit of a conflicting area. Some studies say it increases, some studies say it decreases. But we do know that clonidine is able to suppress that increase in the medial prefrontal cortex, and this drug has been used successfully to treat withdrawal symptoms in patients. So while the exact direction is not known, we do know that there is a change in extracellular dopamine in the prefrontal cortex during withdrawal. And then I just like to mention, because I think it's really important, the cingulate has protections to almost all of the brain regions that have been associated with some aspect of addiction, either rewarding or aversive. And importantly, the periaqueductor gray, which Rue just spent a lot of time explaining, has a very important role. So just summarizing everything I just told you, we know that opioid withdrawal affects dopamine levels in the cingulate. We know that dopamine modifies the activity of cingulate neurons, and we know that cingulate neurons control the activity of downstream brain regions, and these are particularly involved in determining the autonomic state of the individual. So the hypothesis for my overall thesis is that these alterations in the mesocortical dopamine system may be a key factor in generating this hyperkatifia that we see during opioid withdrawal. And if we're able to repair these changes in the dopamine system, can we then treat the hyperkatifia? So sounds great. How do we produce emotional states in animals? I work with rats. How do I ask a rat if they're stressed or if they're feeling good? So our lab has come up with what we refer to as a 3-valence task, which is designed to evoke these states in animals so that we can then measure how the dopamine changes. So the rat's placed in a box, a homemade box with a shock grid floor, a speaker, and a food hopper. And in the first version of this task, the frequency of the tone will then indicate the valence of the outcome. And these are presented in block orders. So we have a positive block, a negative block, and a neutral block. In the positive block, they receive food pellets. In the negative block, they receive a mild foot shock at the very lowest level just to observe some kind of reaction. So it's usually just a slight lift of the paw. And then in the neutral block, there's no outcome. So they hear a 5-second tone, the outcome, this occurs 15 times, and then it switches to the next block. Importantly, every time they go in the box, the order of these blocks is random, so they never know which one will be happening first. And then in between each one of those pairings, there's a random interval of 60 to 90 seconds where they're waiting. I know that's a lot, so we're going to work through a quick example because it's important that you understand this task to understand my data. So if we have example rat 1, he goes into the box and he hears the 6 kilohertz tone, which for him means no outcome. So he is currently in the neutral block. After hearing this tone and receiving no outcome, there'll be a random interval of 60 to 90 seconds, and then this will repeat again. So 15 times he'll hear a tone, nothing will happen, and then there'll be a random interval. After those 15 times, it'll switch to the next block. In this case, it happens to be the 8 kilohertz tone, which for him is the food one. So he'll hear the tone, he'll get 3 food pellets, and then there'll be another interval where this repeats again 15 times. And then finally, he hears the 4 kilohertz tone, which for him is the shock one. He'll receive his mild foot shock, the interval, and then this repeats again. But every time he goes in the box, this order is different. So he may receive foot shock first next time or food first next time. It's not known. And then we made a second version of this task, which is exactly the same. The only thing is that we've now added in a duration element. So how long the tone plays for will indicate the value of it. With a longer tone, will produce a larger amount of food pellets or a longer foot shock. And these are presented in groups of 10, and that's randomized as well. So they don't know which block they'll receive first. And then once that block is happening, they don't know which order the rewards will come in. The reason for adding this was really just to give to make it a bit more realistic to humans, because not everything that's aversive is equally as aversive, and not everything that's rewarding is equally as rewarding. So we just wanted to produce a little bit of a gradient. So the original version of this task we actually did in rats with electrophysiology, and we were able to record the activity of the neurons as the rats did this task. And the main finding was that the overall ensemble activity of the cingulate gets locked into a unique pattern of activity that's dependent on the block that they're in. So we can distinguish the cingulate's neuronal activity depending on if they're in the food, the shock, or the neutral block. And the conclusion was that the neurons are tracking the internal state of the animal evoked by these outcomes. So what I'm looking at now is what is dopamine doing during this task to produce this activity in the neurons that we're seeing. So to measure dopamine in the medial prefrontal cortex, I'm using a technique called fibrophotometry. This allows me to measure changes in extracellular dopamine in the cingulate cortex in vivo with very high temporal resolution, meaning I can see the changes in dopamine as the rat is receiving the food or receiving the foot shock. So this is all done using photosensors that have a modification to the third intracellular loop of the dopamine receptor. It's very simply, it's just been modified so that now when dopamine is bound, there's a conformational change and the fluorescence increases. So I'm shining two different wavelengths of light at it. One of them is dopamine binding dependent and one of them is independent. So with the dopamine dependent fluorescence, anytime dopamine is bound, there will be an increase in fluorescence, and anytime it unbinds, that fluorescence will decrease. And with the independent one, it's just a control. So there'll be some baseline level of fluorescence and it doesn't change depending on binding of dopamine. And that one's just for any kind of movement artifact. So any change in that signal would be due to bending of the cable or movement of the animal. So I've done this in the 3-valence task. All of these figures are using D-Lite 2.1, which preliminary data so far seems to be our worst photosensor, but the results are still pretty good. So just to recap, if the cingulate dopamine is tracking salience and not the valence of outcomes, we would expect to see an increase in this response in response to both the shock and the food, because both of those are very salient things. And that's exactly what we see. So the shock is in blue, and then underneath it is the food in orange. So they hear the tone at the 10-second mark, and then the outcome occurs at the 15-second mark. And as you can see for both, there's a large increase in dopamine efflux in response to both the shock and food. So that's finding one. The other important thing to note from these figures is that the mean and standard deviation used for the Z-score come from the neutral block. So as you can see from the starting point, the shock block is significantly higher than where the neutral is, and then same thing with the food. So what that is telling us is that the actual baseline levels of the dopamine within those blocks are also different. So we tend to see the highest level of dopamine in the shock block, followed by the food, and then lowest in the neutral. And this finding is consistent across animals and across sessions. So it doesn't matter which block is first every time they go in, the highest level of dopamine efflux occurs during the shock consistently. So then in the third version of the task, which is where we added in the duration element, if the cingulate is tracking salience with dopamine, we should see the magnitude of the outcome reflected in the signal, where a more aversive event should be evoking more dopamine or a more rewarding event should be evoking more dopamine. So in this figure, this is just showing the shock block of the duration version. So the blue is the longer shock, the orange is the medium length shock, and then the yellow is the lowest length of shock. The line at 10 is where the tone occurs, and then each arrow is indicating where the shock occurs for each one. And it's exactly the same as we saw in the last figure. We're seeing an increase in dopamine for shock, which is different to what we would expect to see in the mesolimbic pathway. And then also the basal levels of dopamine are highest in the more aversive shock than compared to the other two. All right, so all of this has only been done in control animals, because before we can look at how dopamine is changing during withdrawal, we needed a really good understanding of what dopamine is doing in a cingulate at baseline. But the next step is now to use the injection protocol that Daria has described to see how it affects the dopamine response in these animals. The protocol Daria described is designed to induce opioid withdrawal hyperalgesia. There's a lot of evidence from Koob to suggest that the mechanisms that produce hyperalgesia are also the ones that produce hyperkatifia, and that there is a large interaction between the two. So it's highly likely that in a model where hyperalgesia is occurring, there's also hyperkatifia. And then as well, it would be very interesting to see how these medications that treat hyperalgesia would affect the dopamine response in the cingulate, and if returning the dopamine response is also related to the treatment that we see. And then another mention for future directions, I also study sex differences. So I work with male and female rats. It's really important to mention that overdose disproportionately affects men. So across the board, we always see almost a 75% greater chance of overdose in males compared to females. We know that they're more likely to relapse following periods of abstinence, and that the presentation of withdrawal is quite different between males and females. But what's really interesting is also that there are large differences between males and females in the function and structure of the cingulate at baseline. So we know that the functional connectivity between the cingulate and its downstream regions is different between males and females. This is just at control levels. So males tend to show greater connectivity between their cingulate and the salience network, as opposed to females showing greater connectivity between the cingulate and pain processing networks, which may suggest that these mechanisms that I'm proposing might have a stronger effect in males compared to females. And then also there are sex-specific differences in how the cingulate is changed during withdrawal. So in rat models of withdrawal, you see an increased metabolism in the cingulate during withdrawal that isn't present in females, suggesting that some of these differences may be due in part to changes in the cingulate. All right. Perfect. I think we're done.